We're going to talk about STEMIs. Okay, STEMI is obviously a very important topic, and sometimes it can be a little bit tricky. So, how many of you guys, when you are trying to interpret an EKG, how many of you guys look like this? I'm sure this happens every once in a while to all of us, regardless of what sort of EKG you're looking at. But hopefully, this will give you a little bit better idea, particularly when it comes to STEMIs on identifying some of this. So let's first talk about some basics here, okay? So what is the presentation when you get a STEMI patient? You respond. The typical presentation is a patient that's having left-sided or anterior chest discomfort. It's retrosternal. It can be described in a multiple different descriptions: crushing, squeezing, like a tightening, a pressure. A lot of people will use these exact terms. It feels like an elephant on my chest, or it feels like a ton of bricks on my chest. And this is just your typical presentation. It definitely does not mean every STEMI has this presentation, but a lot of folks have these symptoms. They a lot of times will have associated shortness of breath, nausea, they're diaphoretic, and there's radiation of the pain into the left arm, into the neck or the jaw area, sometimes into the back, depending on where the STEMI is. If a person is saying it's radiating into the right arm, it actually increases the likelihood. So don't ever discount the fact that, oh, the patient says it radiates into my right arm, so that can't be an MI. That's actually not true. Folks that say it's radiating into their right arm have an even increased likelihood that it's a STEMI. The pain typically is worse with exertion, gets better when they rest. Some of the atypical symptoms, and these are things that you might see that you should still be concerned for an MI and do an EKG if they're complaining of just isolated dyspnea, whether they're at rest or exertion. If they're complaining of just isolated shoulder, arm, jaw discomfort. I'll take that further. If they're complaining of upper abdominal pain, we should still be doing an EKG. Sometimes inferior MIs, where the affected area is sitting on the diaphragm, it can cause upper abdominal pain. So you always want to get an EKG on your abdominal pains. If there's isolated nausea, lightheadedness, generalized weakness, mental status changes, a diaphoretic patient, anytime you see a patient that's diaphoretic, you need to be extremely concerned. Patients, unless they've been outside working in the summer heat, unless they're one of our crew members that's been running calls in PPE all day, a diaphoretic patient is always, there's something bad going on, and you need to be very concerned, okay, about an MI, about hypoglycemia, or potentially internal hemorrhaging or sepsis. So always be very concerned when you get a diaphoretic patient that otherwise should not be sweaty in the environment that they're in. And then, of course, upper abdominal pain. These are some of the atypical symptoms. When you see this, you should still be worried and always get an EKG as we all do. The atypical symptoms, a lot of times you see these, it's more common in females. Okay, diabetics tend to get neuropathy because of the damage that they have to their nerves. So diabetics oftentimes get atypical symptoms. Elderly patients will get atypical symptoms. If a patient has a psychiatric disease, not only are they in danger of care providers missing a STEMI, but psychiatric patients oftentimes, a lot of critical illnesses will get missed because we assume, oh, it's just their psychiatrical disease that's causing them to act out when they're having a STEMI. So don't ever discount your psych patients and discount them just because they have psych diagnoses. And then your patients with baseline altered mental status, they got dementia or prior CBA, these folks can have strokes as well. Okay, so always have a high suspicion in these folks. So let's talk a little bit about coronary anatomy. Okay, there's three main there's two main vessels that come off of the aorta that supply the heart. You have your left coronary artery, and you have your right coronary artery, as you can see in this picture. So this is the aorta. Okay, this is the root of the aorta. This is the part that comes off of the heart right here. And you can see there's a right coronary artery that goes towards the right side of the heart, and then you have your left coronary artery. And the left coronary artery, it splits off into two branches that are the big ones that supply the heart. You have your left anterior descending, and then you have your left circumflex, okay? So three main arteries that we look at when we're talking about a STEMI: the right coronary artery, the left anterior descending, and the left circumflex. So the left anterior descending artery, it supplies the anterior wall, the septum, and part of the AV conduction system, okay? The left circumflex is going to supply some of the anterior part of the wall. It supplies a large portion of the lateral wall, and then a little bit of the posterior wall. So the circumflex kind of reaches around to the front, mostly the side of the heart, and it does reach a little bit of the back of the heart as well, okay? And then you have your right coronary artery. The right coronary artery is going to supply the right side of the heart, the inferior aspect, the bottom of the heart, as well as the posterior aspect and the conduction system, okay? So all these are very important. So how do you get coronary artery disease? Anybody recognize this? So normally you start off with healthy arteries, as you can see right here at the top of the diagram here. What tends to happen is over time, as you have damage to the inner walls of that vessel, from high blood pressure, from turbulent flow through these tiny little vessels, you start getting damage to the inner walls of your artery. And what it does is it builds up plaque, okay? That queso, it also doesn't help, but it builds up plaque. And then eventually what tends to happen is that plaque will rupture, okay? And when it ruptures, the stuff that makes up this plaque, it's very thrombogenic, meaning it likes platelets, and platelets like to stick to it. So this eventually it ruptures, and you get a buildup of platelets, and you develop a clot in that artery, which basically causes a person to have a heart attack. So what they do in there is they put a catheter in, they fish a very thin wire past that area that's blocked, and that wire has a balloon that they inflate. And surrounding that balloon is a stent. A stent is basically a collapse, for lack of a better term, it's almost like a collapsed spring, okay? And so when they inflate that balloon, not only does it push all that plaque and blockage to the sides of the heart, but it deploys that stent, and now that wire stent basically holds that blocked up area open and pushes all the plaque and everything to the side, okay? So the first thing we give to a STEMI patient, what's the first thing we give when we get to the scene, we recognize a STEMI? Aspirin. What does aspirin do? It stops all these platelets from clogging up the vessel. It slows down all the stickiness of the platelets, and it helps limit how much occlusion you get. Okay, that's why aspirin is a very simple yet very effective way of treating a STEMI. Okay, before a person gets plaque rupture and near occlusion or complete occlusion, you might have just a partial blockage. And when a patient has this, they might have what's called stable angina, in which they have decreased blood flow to this vessel, and when they try to do something exertional, they get chest pain, but then when they sit down, the pain goes away. That's stable angina, right? So it's not good to have all this plaque in your arteries, guys. So here's the result of what happened, okay? As you get tissue ischemia, this is a cross-section of a heart, okay? This is basically, they took a slice out of a heart, and this is a person that had obviously a lot of MIs. And what happens is, this is a old area of infarction where the muscle is completely dead. There's no blood flow in there. It's completely dead. It's all white. And this part of that circular muscle, it does not work anymore, okay? They've also had other areas of infarction right there and right there, and it's not quite white yet, but it's going to eventually become white and become non-functional. And so when you have a heart attack, it causes you to lose muscle, cardiac muscle, decreases contractility, and these patients eventually end up with congestive heart failure because their heart muscle doesn't work so good. This is a cross-section of a coronary artery with plaque buildup and the platelet clot in the middle. Okay, so that's what it looks like if you look at it under a microscope. So what are the EKG changes? Does anybody know how an EKG evolves as a person gets an AMI? As a person occludes their coronary artery, specific changes occur in the EKG in a stepwise fashion. And these are things that you can identify and look for. And it's helpful to know where you're at in the STEMI. And you know, EKGs are weird. This is classic presentation, but I think we all know it doesn't always happen this way. But in a majority of the cases, these are some of the changes that you'll see in the EKG. So the first thing that actually happens, this diagram left that part out, but the first thing that happens is a change called hyperacute T waves. And what that is this T wave becomes extremely tall and peaked, almost like a hyperkalemic patient would, okay? There's some subtle differences in a hyperkalemic patient and hyperacute T waves for an MI patient. The T wave is not as sharp and pointed, and it's a little bit broader based in a STEMI patient. So the first thing that happens is they get hyperacute T waves, okay? The next thing that happens is they get ST elevation, all right? And you start seeing a Q wave that starts forming, all right? As the MI continues to evolve, that Q wave becomes deeper and your T wave starts to invert, all right? As the MI starts to resolve, you start seeing the ST segment come back down to baseline, and then eventually, over the course of days, the ST segment normalizes and the T wave becomes upright again, okay? So that's from the start, minutes into it, to several days after the MI is complete. You'll have a deep Q wave that is always there. The ST segment may or may not normalize. In some people, it remains elevated, but most of the time it'll normalize back to baseline, and their T wave may or may not go back to an upright T wave, okay? So just some things to look for. So why does the ST segment, why does it elevate in an MI? What happens? Has anybody seen this action potential chart? Do you guys know what this action potential is on how cardiac muscle contracts? It has to do with polarization and depolarization through their sodium channels and potassium channels. And so the QRS complex on an EKG, this is EKG strip, okay? And it shows you how it correlates with the action potential. So the QRS complex, that's the depolarization of the cardiac muscle, okay? That's when it's actually contracting, right? When anything that depolarizes, it has to repolarize. So the T wave, that's when the heart muscle is recharging itself. It's repolarizing. So the ST segment is that time frame in between depolarization and repolarization. And it's going to be flat in a normal situation, okay? However, when you have a heart attack, we saw in that one picture of the heart muscle, it's completely destroying the cells. And when the cells aren't getting blood flow, the membrane potential also goes away. They don't carry a charge anymore. And the difference between the ischemic part, which doesn't have a charge, and the muscle next to it that does have a charge, it causes a displacement in the ST segment. So the ischemia, the area that's not getting blood flow, it disrupts the repolarization process. And not only does the ST segment elevate, but the T wave also will get infected. Okay, and that's why you see ST changes and you see T wave changes. So when we say, what's the definition of an ST elevation MI? What's the definition of ST elevation? So you got to have ST elevation in contiguous leads, right? What is contiguous leads? You got to have ST elevation in at least 2 anatomically contiguous leads. So when you're looking at an EKG, contiguous leads doesn't mean leads that are just on top of each other or leads that follow the same number, V1, 2, 3, 4, 5, 6. No, that's not contiguous. These leads all represent a different part of the heart, okay? And they also represent a different blood vessel, right, that supplies that part of the heart. So contiguous leads, you're looking at the inferior part of the heart, you're looking at the lateral wall of the heart, and you're looking at the anterior or the septal walls, okay? So notice that the EKG, it represents the bottom of the heart, the left side of the heart, and the front of the heart. It doesn't do a really good job of representing the right side of the heart and the back wall of the heart. And there's blood flow to those parts as well, right? So it's important to remember that an EKG, it gives you a pretty good look at a majority of the heart, but not all of it, okay? So what are contiguous leads? 2, 3, and AVF are contiguous leads, and they give you information on the bottom of the heart. 1, AVL, V5, and V6, that gives you the information on the lateral part of your heart. They're completely, you can see they're not connected on the EKG, but these are contiguous leads, okay? And then you have V1 through V4 that represents the front of the heart and the septum, all right? And it's important to remember which blood vessels supply which part of the heart, right? So the lateral part of the heart, if you remember the coronary artery diagram I showed you, the lateral wall of the heart is supplied mainly by the left circumflex, but the left circumflex is the main artery for the lateral part of the heart. The bottom of the heart is usually supplied by the right coronary or the left circumflex, just depends on where you are at the bottom of the heart. And then the anterior and the septum is supplied by the left anterior descending, okay? You gotta see reciprocal changes, right? And you don't always see reciprocal changes. It kind of depends on where you are in the STEMI. If it's early on, you may not see reciprocal changes yet. But what is a reciprocal change? It's basically the opposite of ST elevation that you see in the leads that are opposite of the STEMI leads. So if you have ST elevation in 2, 3, and AVF, which is the bottom of the heart, then you should see ST depression in T-wave inversion. That's the opposite of ST elevation, right? The opposite of ST elevation is ST depression. The opposite of an elevated T-wave is T-wave inversion. So you should see those changes in lead 1 and lead AVL, okay? If you have a high lateral STEMI, so that means ST elevation in 1 and AVL, then you should have ST depression in 2, 3, and AVF, all right? If you have ST elevation in V1, 2, 3, and 4, that's the anterior wall of the heart, right? Where are you gonna see your reciprocal changes? Because what did I say? The opposite of anterior is the posterior wall, right? And there are no leads on a normal 12 lead that represent the posterior wall of the heart, right? And that's why you can do a posterior EKG, right? So there's nothing that represents the posterior wall in a normal 12 lead. So if you have there's no real way, if you just run a normal 12 lead, look at this. There's no way to know that you have a posterior ST elevation MI because the posterior leads aren't represented. The posterior wall of the heart is not represented in a normal 12 lead. So the way you know you have a posterior MI is you have reciprocal changes in V1, 2, 3, and 4. If you see some ST depression, then you might want to consider doing a posterior EKG because there might be a posterior MI going on. Definition of an ST elevation MI. Now this is very important, okay? So you got contiguous leads, you look for reciprocal changes. How much ST elevation do you actually need to call this an MI? All right? There's very specific numbers. This is a very important slide. Make sure you know this slide, okay? So if you have males greater than 40 years of age, V2 and V3, the anterior leads, you got to have greater than or equal to 2 millimeters of ST elevation for that to be an MI. In all other leads, greater than 1 millimeter, okay? For men less than 40, you got to actually have even more ST elevation. You got to have greater than or equal to 2.5 millimeters in V2, V3 for it to be an anterior MI, or 1 millimeter in your other leads. And women, for all ages, they have to have at least 1.5 millimeters in V2, V3 if it's going to be an anterior MI. You got to have at least 1.5 millimeters, okay? And notice that it's only in V2, V3, right? V2, V3, those are the leads that represent the anterior wall of your heart. And a lot of times you'll see what's called J-point elevation in V2, V3. And that's why it requires a much larger elevation than all the other leads, in which 1 millimeter seals the deal in all your other leads. If you have 1 millimeter 2-3 AVF, you're done. You got 1 millimeter in V5, V6, lead 1 AVL, you're done. That's a lateral MI. But in V2, V3, there's usually J-point elevation in a lot of patients, particularly young patients. And so in order to know, is this J-point elevation or is this a MI, it requires a little bit more elevation than in all your other leads, okay? What about if you do a right side EKG? How much ST elevation should there be? So in a right side EKG, if you do a right side V4 lead, you need at least 0.5 millimeters of ST elevation. If you have some unfortunate male who's younger than 30 and they're having an MI situation, they need greater than 1 millimeter on the right lead in order for that to be considered a true ST elevation MI, okay? And then your posterior leads, V7 through V9, you do a posterior EKG, you're concerned that there's a posterior wall MI going on, that also, you need a 0.5 millimeter ST elevation, okay? So for right side and posterior EKGs, the ST elevation segment is not as high as all your other normal leads. So important to remember these measurements. Now, what if you got a picture, you got somebody, oh my God, this guy looks like he's having a heart attack. You do an EKG, and he's got, let's say he's a 50-year-old, and he's got 1 millimeter ST elevation in V2, V3. Do you still call it? If it looks like a STEMI, if the guy acts like a STEMI, and he tells you all the right stuff, yes, you still call it, okay? And what you do is you repeat the EKG, okay? You watch and see if there's evolution of it. But for all intents and purposes, these are the technical definitions. Am I actually looking for 2 millimeters? No. If I got the picture of a STEMI on a patient and there's ST elevation, then yeah, chances are you need to call it, okay? But every once in a while you'll get an EKG, the patient's complaining of toe pain, and for some reason you do an EKG and you see, whoa, is this a STEMI? There's ST elevation. This patient doesn't look like he's having a heart attack. He's complaining of toe pain, but this is where these measurements come into play, and it's good to have this knowledge. So again, I'm gonna just go over the 12 lead and the arteries, okay? So again, inferior, that's 2, 3 and AVF. It's represented by your left circumflex and your right coronary, okay? Your lateral leads, 1 AVL, V5, and V6. That's going to be your left circumflex. And then V1 through 4, which is your septum, and your anterior, that's your LAD, okay? Makes you look smart when you tell them, yeah, I think this guy's having a massive LAD occlusion. We're bringing in a STEMI that's got 2.5 millimeters of ST elevation in V1, V2. So just, you know, these are brownie points. I don't expect you guys to remember that, but it's good knowledge to know because it will affect some of the treatment, okay? So how about some examples? You guys want to look through some EKGs? You guys still awake? Are you there, Bueller? Anybody need some coffee? I've given you all the knowledge. You know what to look for now. What do you got here? Is this a STEMI or is this not a STEMI? Everybody is symptomatic in this PowerPoint. There's definitely, you know, if this person, if I tell you it's a 50-year-old, he's having chest pain and short of breath, there's definitely some, how much ST segment is there? There's 1, 2, 3 millimeters of ST segment elevation here in V2, right? And as well as in V3, we have over about 3 millimeters right there as well. And then in V4, you have greater than 1 millimeter. So remember, in V2 and V3, if it's a 50-year-old, you got to have more than 2 millimeters of ST elevation, which this patient does. This is a STEMI, okay? Now, what kind of STEMI is this? What wall is affected? LAD, that's correct. And which wall is it? Is it the inferior? Is it the lateral? Is it the posterior? Lateral, septal, anterior. So remember, V2, V3, V4, that's right, septal and anterior, right? There may be some subtle T-wave inversion, maybe a little depression going on here. There may be some inferior involvement. That may just be reciprocal changes. But EKGs, you know, the rules that I told you, sometimes they won't play. We'll see some examples here. But technically, in an anterior MI, right, what's the opposite of the anterior wall of the heart? The posterior wall. And remember what I said, none of these leads will show you the posterior wall of the heart. So you may not see reciprocal changes in a person that's having an anterior wall MI. Okay, so if you got the right situation, you got the right presentation, and you see this EKG, you're going to call this a STEMI, even though there's no reciprocal changes, because you're not going to see reciprocal changes in an anterior wall MI if it's just an anterior wall MI. Okay, so very good. And also, by the way, look at these T waves right here. Look how peaked and large they are. This is a perfect example of hyperacute T waves right here. Okay, so if this person doesn't get treated and you keep repeating EKGs, what's going to happen is this ST segment is probably going to continue to elevate, and it's going to turn into the classic tombstone pattern. But you can see in the non-ischemic leads, it's not much ST, or the T waves aren't that prominent. But in 2, 3, 4, even a little bit in V5, you got some pretty prominent T waves there. So that's an example of hyperacute T waves. Okay. All right. So here's another one. We got a person that's having, let's say, 55-year-old chest pain. It's an elephant on my chest. Is this a STEMI? What are you going to do if you run a call today or tomorrow when you're on the truck and you get this EKG? You guys aren't going to call it? I'm having an elephant on my chest. Aren't you going to do something? I'm dying over here. Can you give me a towel? I'm pouring sweat. It's a lateral. Okay, good. So what vessels is this going to be? Circumflex. Excellent. So this could be circumflex. It may also be LAD. It could be two vessels, right? But it's probably the circumflex, okay? Because it'd be extremely unique to have two vessels occluded at the same time, and you're having a heart attack in two vessels at the same time. But so you can see here that you got ST elevation here in V2. V3 is significantly elevated, and then it goes on into V4, V5, as well as V6, right? And then what are your other lateral leads? You got ST elevation in AVL, you got ST elevation in lead 1. So you got 1 AVL, V5, and V6, so you got a lateral wall infarction. You're also having an infarction in V2, V3, V4, so the anterior septal wall is occluded. And if you look at lead 3, you're starting to get some reciprocal changes here. You have ST depression. And 2, 3 AVF, those are considered reciprocal to your lateral leads. So 1 AVL, V5, V6. So that just helps confirm, yeah, this is definitely a lateral wall MI. Okay? How about this one? What if you got this EKG right here? Is there an MI here? Let's say, I'm going to give you a scenario here. This is a 55-year-old. He's got a history of coronary artery disease. The call for altered mental status, you find that the sugar was 25. You correct it with D10, but you're a good medic, so you do a full neuro assessment. You find there's no stroke. You do an EKG to make sure there wasn't anything that caused some sort of syncopal episode. You ask the patient, are you having any chest pain or anything? The patient says, no, I feel fine. I feel great now that you gave me that D10. And no, I don't want to go to the hospital. I'm better now. What are you going to tell that patient? Sign here? Is that what you're going to say? I hope not. So what this is a presentation of a left ventricular aneurysm, okay? And that's something that a person that's had a previous MI, they can develop an aneurysm on the wall of their left ventricle. And the changes that you'll see on their EKG is ST elevation. But look at this EKG, right? It looks like they're having an anterior or septal MI, right? With the ST elevation in V2, V3. However, look at these Q waves they have here. They've got some extremely deep Q waves, okay? So ST elevation, deep Q waves, has no symptoms of an MI whatsoever, although you're all very correct. I would still very much encourage this patient to be transported because you're right, diabetics, we don't have privy to old EKGs, and this guy obviously doesn't even know that he's had a heart attack, so you absolutely 100% want to encourage the person to go and be evaluated with this EKG. But what they may find is he's got deep Q waves. ST elevation is something that left ventricular aneurysm can cause, and you'll have a patient that has no symptoms of an MI. I've actually had a patient like this. Patient had no symptoms of an MI, but his EKG is looking like a massive STEMI. And this was in a very rural hospital I was working in. Boy, we flew that patient out of there because until otherwise confirmed, it's a STEMI. So you always want to call it right, but this is just a unusual presentation that can sometimes occur, okay? So whether they're symptomatic or not, you see something this bad looking, you're better activating it and letting the cardiologist and the physician figure out based off of old EKGs if this is something that's been there or if this is something new, okay? So what about this? What's going on here? 65-year-old, chest pain, short of breath, sweating, about to code. Yeah, you're right. Why are they about to code? They got massive tombstones. That's right. Okay. So this is a massive MI. Tony, you're fired. This is a massive MI, right? Anteriorly, and it's extending laterally, right? So what vessel are we looking at here? Circumflex, right? And so how do you know? Well, look at this. I mean, this doesn't even look like this doesn't even look normal anymore. But 1 AVL, these are extreme ST elevation, 5 and 6. And then down here, you've got ST depression, right? ST depression. So reciprocal changes to the lateral infarction, 1 AVL, 5 and 6. And you've got anterior extension. So this is probably circumflex, okay? What if I told you this is a patient that is not having any chest pain, but they're on dialysis and they missed dialysis all last week? What are you gonna do? Calcium, right? What else does this resemble? Hyperkalemia, and this is getting close to a sine wave. Which one are you going to give first? Calcium first, exactly. Calcium is going to help narrow that down. What if you give that first calcium and it still doesn't narrow after the first 5 minutes? Then what are you going to do? You repeat it, okay? And you can chase it down with some bicarb as well. It's not going to hurt. And what you'll see is you'll see it narrow down. And it happens relatively quickly, but sometimes it may take more than 1 amp, okay? But just know this is a pattern of ST elevation MI. The patient's having the right symptoms. This is a STEMI, okay? And this can also resemble hyperkalemia. So keep close eye on this. So here's another pattern, okay? This is also, so this actually, you give this person calcium and they may narrow down to this sort of a EKG, okay? But this is also a pattern of ST elevation MI. It doesn't look like the typical kind, but this looks bad, okay? This person is in grave danger, and there's a very high chance this person could potentially go into cardiac arrest on you very quickly, okay? So this is somebody that you got to be extremely prepared for. All right, what do we got going on here? Who's going to call this a STEMI? It's a little hard to read V2, V3. You're picking up something there, though, right? You're seeing, well, maybe it looks a little abnormal. So this is an example of what's called Whelan syndrome, okay? And what this is this is a presentation where this is called a biphasic T wave, okay? There is some ST segment elevation there, but there's not enough, right? This is V2 and V3, and you gotta have at least 2 millimeters if the patient's older than 40. So this person only has about 1 millimeter. This isn't gonna qualify for a STEMI. Technically, it's not. If the patient has all the right symptoms, then you definitely want to call this a STEMI, okay? Or you want to activate it at least. But what this is it's Whelan syndrome. And when you see this biphasic T wave in the anterior leads, V2, V3, with some T wave inversions, this is significant for LAD occlusion. Most of these patients end up finding LAD occlusion on these patients. So this is somebody that definitely needs to go to the cath lab. If you happen to, now remember, if the person is having STEMI-like symptoms, then this is obviously concerning and you probably want to activate it. What if you pick that patient up for toe pain, you happen to do an EKG and you find this? Should you activate it? You want to get a cardiac history. If they're having no symptoms of a STEMI, you probably don't need to activate it, okay? Because that person might have an LAD occlusion there, but it's not causing an acute heart attack at the moment. But it's definitely something that you definitely want to, when you take the patient, you want to bring them you want to bring this EKG to the attention of the physician that, hey, man, I think this guy might have some LAD occlusion here. They may want to repeat the EKG or make sure the guy doesn't develop any symptoms, okay? So this can be, if the person is having symptoms, chest pain and everything, you definitely want to be concerned. And, you know, you activate it, tell them, hey, we're bringing in a patient. He's got Welland syndrome and he's having symptoms of an MI. We want to activate this. If the person's having toe pain, bring it in. Obviously, you don't going to activate a toe pain for STEMI activation, but you want to bring it to the physician's attention. Hey, doc, we did this EKG because the patient also complained of some remote chest pain 2 days ago, and he's got these biphasic T waves. We were worried he might have something going on there. Okay, so that's something that's a pattern to make sure you know and recognize. Here's another one. What do you think about this one? Is anybody going to activate this? So this is, there's a bunch of inverted T wave, deeply inverted T waves here, anteriorly, right, and into the lateral leads. So deep inverted T waves, it might mean there's some ischemia going on, okay? But when you see this pattern with these significant T wave inversions, this is type B Welland's. So there's a type A Welland's, which is this biphasic T wave, and this is a type B Welland's. And this is also significant for LAD occlusion, okay? What are some other things that can cause deeply inverted T waves like this in a patient? PE, that's exactly right. A PE can cause deep T wave inversions like this, okay? What's the classic pattern that you might see? You see it over here. Anybody remember what it is? S1Q3T3, that's right, that's exactly right, okay? And you can see this person does not have a S1Q3T3. That's you're gonna see a S wave in lead 1, a Q wave, and an inverted T wave in 3, okay? That's what S1Q3T3 is, okay? And it's not indicative. You'll see if you start looking at your EKGs, you'll find it on a lot of your EKGs, but it's not a slam dunk that the person has a PE. But these are just some things to look out for based off what other symptoms your patient is having, okay? But this is a type 2 Welland's, and it's also, it might indicate that the person has a big LAD occlusion. So you definitely want to make sure you bring this to the attention of somebody. Okay, what about this one? Who's calling this a STEMI? Let's go. You got a super fast EMT. You're at the traffic light. You're on Beckham already. You calling this or not? We doing this today or are we not? Well, where's the ST elevation? It's not really any, right? This is a pattern. It looks bad, right? Does it look kind of worrying here? It's kind of a worrying pattern, right? You got some really big T waves here, right? That might be hyperacute T waves, but your ST segment is depressed, okay? So this is a unique pattern. This is a unique finding, and this is called De Winter's T waves. Hyperkalemia, that's also a possibility here, right? But this is a pattern called De Winter's T waves, and it's basically in your precordial leads, you got these peak T's with ST depression, okay? This is an anterior STEMI equivalent. So even though there's not ST elevation, you should call this a STEMI activation. You're gonna look like a rock star. You call it in as a STEMI, you'd be like, yeah, I got this EKG with De Winter's T waves. It's an anterior STEMI equivalent, so I went ahead and activated it. And you'll look really good. This is an extremely rare finding, okay? 2% of the cases end up having this pattern, okay? But there's a couple of things that are really worrisome, right? It looks like you could mistake this for hyperacute T waves and you'd still be right because this person's probably having an MI if they're complaining of chest pain, okay? The other possibility is hyperkalemia. Greg mentioned hyperkalemia. That's definitely a possibility here as well if you got the right pattern or the right scenario here. So you should always keep these things in mind. But ST depression, tall T waves, De Winter's T waves, remember that one, okay? That's a good one. All right, you guys tired? Need a break? We'll get back right to it. What's this one going on? What's this? There's a lot of depression. So again, guys, this is De Winter's T waves. You already forgot it. Look, I just showed it to you. So you got ST depression with peak T waves, right? ST depression, peak T waves. Big ST depression right here and big peak T waves. This is de Winter syndrome. So this is a LED occlusion, anterior STEMI equivalent. Okay. So remember the patterns here. I'm going to show you this one. Okay. Look at V5, V6. It looks kind of similar, but de Winter's T waves. It's extremely rare, 2%. So de Winter's T waves. Okay. Remember that one. It'd be an extremely rare case if you find this. What do we got going on here? Is this a STEMI? You may do a posterior. Okay. So AVR elevation, widespread ST depression equals STEMI. Okay, good. So make sure you look at all the leads, right? AVR, and even on the previous slides where I showed contiguous leads, you noticed AVR was not represented, the forgotten lead, okay? And look at AVR, you got ST elevation right there. Even in V1, you got ST elevation right there, okay? And you got some kind of ischemia pattern here, ST depression, which is always concerning for ischemia. So when you have AVR ST elevation, that can mean one of two things, okay? That can mean you have triple vessel disease, in which all three of your vessels are occluded and this person is going to need a bypass, or it could mean that their left coronary artery. So remember, you got two vessels that come off the aorta, the right coronary and the left coronary. And the left coronary branches into the LAD and the left circumflex. This AVR elevation might indicate that their main left coronary is blocked and that they're not getting blood flow to the circumflex or the LAD, okay? So don't forget to look at AVR, okay? The other thing is there's ST depression with upright T waves in V4, V5, V6, even in V3. So you always got to be concerned that is that reciprocal changes for infarction that the normal 12 lead isn't picking up, all right? So in these kind of situations, if you're not sure, try doing a posterior EKG, okay, and make sure you're not missing something back there. Okay, what do we got here? Anybody see a STEMI? And it's a subtle pattern, right? I mean, I know it's always hard to do EKGs on the screen, but it's a very subtle pattern. But yeah, just assume everybody has a chest pain presentation. But yes, they're developing ST elevation. In lead 2, it's starting to elevate. Lead 3 is definitely elevated, and that's probably a millimeter. And even AVF, it's got this really weird pattern, but here's your baseline, and your ST segment is up here, so certainly elevated here, okay? Now, what causes an inferior MI? What are the two vessels that could potentially cause an inferior MI? Circumflex or RCA. So which one is this? Is this a circumflex occlusion or RCA occlusion? So that's when doing a right-sided EKG becomes important, okay? Somebody answered 3 and AVF elevation greater than 2. Right, okay? So you want to know, because if it's an RCA occlusion, these folks are very prone to becoming extremely hypotensive. So that's why, you know, the previous teaching was, oh, don't ever give an inferior MI nitro because you don't know if it may be right-sided or not. Well, that's why you do a right-sided EKG, okay? They're prone to getting extremely hypotensive on you. All right, what's going on here? Where's your STEMI? Very easy to see here, right? And is this how far along in the MI is this patient? Looks like they're kind of getting into it fairly advanced, right? You got Q waves that are starting to develop, fairly deep Q wave, and you're starting to get T wave inversions here. Okay, so this person's moving along into this MI. It's probably been going on for several hours now, right? You want to get this guy to the cath lab. He's probably lost a good bit of his heart tissue here. All right, what do you got here? Where's your MI? So yeah, 1 huge ST elevation, AVL. You also have ST elevation V5, V6. Remember, how many millimeters do you need in all your other leads? 1 millimeter, right? You definitely got it here, and you got it here as well, okay? So what vessel is that? Left circumflex, right? And your reciprocal changes are gonna be inferior, so 2-3 AVF, and sure enough, there they are, okay? How about this one? This is a completed MI. This is a person that's completed their infarct and gone to normal. So there's still maybe a little subtle ST elevation in AVL, maybe even in lead 1, but they've got Q waves here, they've got inverted T waves here, and there's no other ST elevation anywhere else. Even in 5 and 6, they've got their Q waves and they've basically gone back to normal. This is a patient that's already completed everything. Okay, so no ST elevation here, but they're complaining of chest pain. I've been having chest pain for days. Well, what made you call today? Well, I figured I better go get it checked out now. So the MI's done, the damage is done here. All right, what do you got here? Anterior, right? Look at your T waves. Hyperacute T waves. Look how big these T waves are. Those are not normal T waves compared to all the other ones. So you got hyperacute T waves, right? You got greater than 2 millimeter ST elevation. Okay, so this is a STEMI already. And you're seeing some reciprocal changes in your inferior leads, which goes against the theory, but there's definitely an MI going on here. Okay, and remember, hyperacute T waves. That's a very early component of a STEMI. Most of them have ST elevation already too, though. Okay, what you got here? Lateral, yeah. What do you think about AVF and lead 2? So what vessel is going to cause an inferior as well as lateral MI? Circumflex, proximal circumflex. It's going to knock out your lateral wall, because remember, RCA doesn't do too much coverage on the lateral wall. So if you got lateral involvement, you're probably looking at your circumflex, okay? And you got pretty good lateral involvement here, but you also got inferior involvement there. And there's something, this ST depression with an upright T wave, that's the opposite of ST elevation, right? So this person actually has posterior MI going on as well. What's this all about? Are these getting tricky enough for you? Is this a STEMI? So let's take a look at this, okay? This is a very unique EKG, right? Looking at it, maybe there's some ST elevation in lead 3, okay? So there's a millimeter in lead 3, all right? There's probably a millimeter in AVF as well. So you got enough to call an inferior MI, okay? But look at your anterior leads. Anterior is opposite of what? The posterior wall, right? And what do you have here? You have a R wave, right? It's the opposite of a Q wave. You have ST depression, which is the opposite of ST elevation. And you have upright T waves, which is the opposite of T wave inversion. So you're basically looking at the reciprocal changes of a posterior wall MI here. So when you do 7, 8, 9, stick them on the back, you got 0.5 millimeter of ST elevation here. You're done. There's your posterior MI. Okay? So when you see that pattern of ST depression and upright T waves in your precordial leads, always do a posterior EKG, all right? And how do you do a posterior EKG? Well, you can, I think it's easier, this gets confusing when you do this, but you can basically leave 4, 5, and 6 on, but take 1, 2, and 3 off and put them on the back, V7, V8, V9. And you basically put it at the lower tip of the scapula, just to the lateral aspect of it, which is the posterior axillary line, and then on the medial edge of the scapula. That's where V9 goes, okay? So when you have posterior extension of an inferior or a lateral MI, you got a really big part of the heart that's getting damaged here. And this person is very likely to go into cardiac arrest and die, okay? That's why it's extremely important to know if the posterior wall is being infarcted. This is obviously something that you need to activate and needs to go to the cath lab immediately. But given that the EKGs look like this, posterior MIs get missed all the time because they assume, well, that's not really a STEMI. The patient probably has some ischemia going on, but they're not having an MI. This is an MI right here, guys. You're just looking at the mirror image of it, okay? So don't let that fool you, all right? Because some poor person is going to end up with potentially dead or with a very handicapped heart because all their heart muscle is infarcted and doesn't work anymore, all right? So anytime you have an inferior MI or a lateral MI, that's your circumflex and your RCA, remember, they both wrap around to the back wall of the heart. You probably want to shoot a quick posterior EKG and make sure that you're not missing a posterior MI, okay? And remember, it's a very subtle finding. It's 0.5 millimeters. It looks very subtle. So you see 0.5 millimeter of elevation in 789, that's a STEMI, okay? How about here? What do we got here? Is there any ST elevation? 3 in AVF, okay, maybe. There's just some kind of an upslope there, right? Yeah, maybe AVF. You can maybe call something there. V2 looks a little funny. But I'm not buying it. Let's just hold off, right? We can bypass. We're coming from Alto. We'll bypass Jacksonville. Let's just go on Tyler. So 30 minutes later, this is a repeat EKG. Anything changing here? 3 AVF. They still look about the same, right? Not much changing. 3 AVF look the same. You got this biphasic situation going on in V2, V3, right? V2, V3, right? But one of you smart medics that sat through this course looked at the EKG and said, hey, why don't we do a posterior? So they did a posterior, and look at this ST elevation right there, 0.5 millimeters. And this whole time, this person with ST depression, upright T waves, is having a posterior wall MI, okay? So long delay killed all this patient's cardiac muscle. Now he has CHF, ejection fraction of 10%, and we'll be enrolling him in our MIH program to follow him for the next 30 days, okay? And you can see what they did here. They took off V1, 2, 3, and they put it on the back and made it 7, 8, 9. And that just, to me, seems easier, okay? So very deadly posterior MIs, very dangerous and bad situation if it goes unrecognized. So remember that pattern: ST depression, upright T wave in your precordial leads, and maybe iffy lateral leads or inferior leads. Get that posterior EKG, guys. Okay, this person's going to have a very bad outcome if we don't identify it. All right. So what do we got here? What sort of STEMI? So you got an inferior, right? So is there right side involvement in this one? See, it extends into the right wall of the heart.
Could be, because you have some reciprocal changes in AVL to the lateral, so you could be having some.
It's a possibility, right? So do you guys know the rules on how to determine if there's right-sided involvement in an inferior MI? So we know if you got an inferior, you always want to look to make sure there's no posterior involvement, right? And there's not. There's ST elevation here. There's not ST depression with upright T waves. So we know, okay, the back of the heart is good, but the right side of the heart. So you look at lead 3 and you look at lead 2, all right? And if the ST elevation is greater in lead 3 than it is in lead 2, and you have ST elevation in V1 as well, it's likely that there's right side involvement, okay? So how do you do a right-sided EKG? It's a very easy thing to do, all right? You can do a full right-sided 12 lead in which you put all your leads basically on the right side of the chest, or you can just take V4 and move it over to the right side, and that's labeled V4R, okay? And V4R is found to be a very good detector that there's right side involvement. And remember, you want to see 0.5 millimeters of ST elevation in V4R, and that seals it that there's also right-sided involvement in this inferior MI, okay? And this is important because you want to be careful with that nitroglycerin, and you want to have your fluid spiked and ready to go, because if these patients get hypotensive, they usually require very aggressive fluid resuscitation because that right side is not pumping properly, okay? The other thing, if there's right-sided involvement and the RCA is the occluded branch, the RCA is the supply for the AV node. So these patients are likely to develop heart locks, okay? So you also want to have pacer pads and everything on all these patients. All right. So here's an example of the V4R. So here's that same EKG, right? Here's lead 3, here's lead 2, and they did a V4R, and you can see this guy has way more than 0.5 millimeters of ST elevation here. So there's definitely a right-sided ischemia and likely RCA involvement here. Okay, so RCA occlusion, it's suggested when ST elevation is greater in lead 3 than in lead 2. Okay, you got reciprocal ST depression in lead 1, and remember, lead 1 is lateral, right? So if there's right-sided ischemia, then you should see reciprocal in lead 1, and signs of right ventricular infarction. So that's ST elevation in V1 and in V4R. All right. Circumflex, left circumflex occlusion is suggested if lead 2 and lead 3, the ST elevation is equal in there. There's not, lead 3 is not bigger. You don't see reciprocal changes in lead 1. And if you don't see infarction in your lateral leads, or if you got infarction, signs of ST elevation in your lateral leads, then you know you're dealing with your circumflex. Because it's going to be rare that you occlude your circumflex and you only get the back of the inferior of the heart. You're typically going to see the lateral wall of the heart also getting infarcted. Okay? Okay. So, is this a right-sided STEMI? So let's go through it. Is lead 3, is the ST elevation greater than lead 2? Yes. Okay. Do we see any signs of lateral infarction? Do we see ST elevation in V5, V6, 1, or AVL? No. Are you guys seeing something and I'm not? There's no elevation there, right? So your circumflex is not likely involved, right? And you do have reciprocal depression in AVL, and you got, not really in lead 1 here, but, in lead 1 in AVL you do. So this is very likely that there's RCA involvement here, okay? So on this same EKG, they do a V4R here, all right? You can see V4R right here, and you can see there's a 0.5 millimeter of ST elevation there. So you know this is a RCA occlusion, okay? Well, that's a whirlwind of EKGs, okay? I hope you found it educational. I hope that was informative. I know we can't do in-person training, but this is kind of, I guess, the best way we can do it. So a couple of closing tips. If you have a patient who's got symptoms and they're suspicious for MI, or you're concerned that they have an MI, but their EKG doesn't quite show it, repeat the EKG, okay? Leave the leads on, leave them connected, and repeat the EKG, in a couple of minutes and see what it does. You got to remember, an EKG only gives you information for that second that you printed out, okay? If you repeat it in 2 minutes, you might see, whoa, this guy's starting to get hyperacute T waves, or those hyperacute T waves are starting to get ST elevation, and this is looking like a STEMI. So always be sure to repeat your EKGs if you don't have a slam dunk, okay? Use PULSARA. Use something. Activate the cath lab, all right? PULSARA is the HIPAA compliant and the best way to transmit the EKG. It immediately gets it to the cardiologist, so that way they can take a look and confirm or say, no, I'm looking at a previous one. This doesn't really look like it's changed any. Or they can say, well, I'm not convinced. Let's get him here and take a look. But you want to activate, and you want to be able to get that EKG submitted, so that way they can take a look at it and help make that decision. Okay. The other thing, and I met with the cardiologist recently, but it's also a really good way for the cardiologist to give feedback back to us, because they can reply back in the text thread and be like, yeah, we took him to the cath lab and we found 90% LAD occlusion. A lot of times they can shoot a video of the actual cath where, it was occluded and after they put the stent in. So it's actually a good way to get feedback. You submit the EKG, you take the patient to the cath lab, and if you type in there, could you please send us feedback? I bet you the cardiologists will do that. I think they're pretty proud of their work whenever they open up an occlusion. They like to share that a lot with a lot of people, okay? And call report immediately, okay? It's the most important thing you can do. You know, we get on the scene, chest pains, we get EKGs very quickly. Soon as you spot that STEMI, call report right there, okay? It's not necessary that, you know, you got to load the patient up, get aspirin, get nitro, get an IV, and be 5 minutes away before you call report. Soon as you see a STEMI, call it, call report, call radio. You can radio first com, be like, hey, we got a STEMI, we'll be there in 15 minutes. Because you got to remember, especially if it's after hours, sometimes even during hours, they got a lot of pieces that they have to move to get the cath lab activated, okay? The cardiologist has to get there. The whole cath lab team has to get there. They got to make sure that they have enough time. They have a 20-minute time frame to get there, but if we're calling in that we're bringing a STEMI 5 minutes before, that really doesn't do the patient any justice. That patient's just going to be sitting in the ER waiting for everybody to get there. So as soon as you identify on the EKG you got a STEMI, the first thing, call it, okay? Activate, call report, and get the cath lab team activated, okay? And then lastly, you know, because it's still greater than halfway into 2020 and we're still in COVID-19, be sure to social distance, okay? In case you've forgotten, we're still in the middle of a pandemic. So that concludes this talk. I hope you guys enjoyed it. I hope it was educational. You guys learned something. We will go ahead and adjourn.